Welcome back to this next video in which we are discussing cardiac arrhythmias. Okay, so we're now actually going to begin going through the different types of arrhythmias. So as promised, I'm going to work through it in this order where we begin with the supraventricular arrhythmias and then go on to the ventricular arrhythmias. And we're going to start with the supraventricular arrhythmias at the most logical place, which is problems with the sinoatrial node, this cluster of cardiomyocytes which commences the entire electrical signal. It's the cluster of cardiomyocytes that creates the action potential every 0.8 seconds to give you a heart rate of around 75 beats per minute. Okay, right. So we're going to discuss things that can go wrong with the sinoatrial node then. Now, the first thing that I want to talk about is something called sinus arrhythmia, and how this is not actually a pathological arrhythmia at all. This is a perfectly physiological phenomenon. Okay, so I want to firstly get that piece of confusion out of the way, because do not refer to arrhythmias that are due to the sinoatrial node having problems as sinus arrhythmias, because sinus arrhythmia refers to a perfectly physiological phenomenon. Okay, so let's begin by talking about what sinus arrhythmia is, and then we'll talk about the actual pathological arrhythmias. Okay, so sinus arrhythmia. So as I say, this is a perfectly physiological phenomenon. Okay, and this is the phenomenon that your heart rate varies all the time on a rhythmic basis, and it varies with the respiratory cycle. So depending on which point of the respiratory cycle you are currently in, inspiration or expiration, your heart rate will vary. And this phenomenon is known as sinus arrhythmia. So it's a perfectly physiological phenomenon. It's usually more pronounced. The fluctuation in heart rate is usually more pronounced in children than it is in adults. Okay, so let me just talk you through what's going to happen. So the two main portions then of the respiratory cycle are inspiration, which is where you're breathing air into the lungs, okay, and then of course expiration, which is where you're breathing air out of the lungs. Okay, now during inspiration, what happens is the heart rate goes up. Now that's perfectly logical because you're bringing air into the lungs, so there is an opportunity for the blood to get a lot of oxygen from that air. Okay, so you want to have a lot of blood being pumped through the lungs. You want pulmonary perfusion to go up. So it's perfectly logical that you would want heart rate to go up so that you can harvest, if you like, as much of the air that has now been brought into the alveolar spaces as is possible. Okay, so during inspiration, heart rate goes up, and then in expiration, it goes back down. Okay, and that is the phenomenon, quite simply, of sinus arrhythmia, that the heart rate varies all the time with the respiratory cycle. And as I say, this variation of the heart rate during inspiration and expiration is more pronounced in children than it is in adults. Okay, so what actually causes this? Why does the heart change the rate at which it's beating during inspiration and expiration? We've answered why, but let's answer how. Okay, it's that the parasympathetic nervous system, its stimulation of the heart varies rhythmically with the respiratory cycle. So during inspiration, the parasympathetic nervous system input goes down, so the parasympathetic nervous system is stimulating the heart, or rather repressing the heart, less during the inspiration phase than it is during the expiration phase. So the parasympathetic nervous system tone goes up during expiration. So remember, the parasympathetic nervous system, that's releasing acetylcholine onto the heart, and acetylcholine slows the heart rate. Okay, it slows the sinoatrial node rate at which it's firing action potentials, and it also has that negative dromotropic effect to slow the conduction of action potentials through the atrioventricular node. Okay, so during inspiration then, the parasympathetic nervous system tone goes down on the heart, which then causes heart rate to increase slightly. That increases pulmonary perfusion and allows you to harvest as much of the fresh oxygen as possible. And then during expiration, where you're getting rid of the air, heart rate goes down because the parasympathetic nervous system tone goes back up. Okay, so that's a perfectly physiological phenomenon. It is not a pathological arrhythmia, so do not refer to arrhythmias that are as a result of problems with the sinoatrial node as sinus arrhythmias. You must call them arrhythmias as a result of a problem in the sinoatrial node. Okay, so that's the first bit of confusion out the way. Now let's actually talk about the pathological arrhythmias. So there are two major things that can go wrong with the sinoatrial node. Either it can fire action potentials at a too low frequency, or it can fire action potentials at a too high frequency, i.e. it can lead to bradycardia and to tachycardia. Okay, so these are the two major divisions of problems with the sinoatrial node then. So we have what is called sinus bradycardia, and then we'll have sinus tachycardia. So let's begin with sinus bradycardia and go over the different things that can actually cause sinus bradycardia, and then we'll talk about the treatment, and then we'll move on to sinus tachycardia. Okay, right, so sinus bradycardia. Sinus bradycardia, we've talked about what the definition of bradycardia is. Bradycardia means that the heart rate is going to be less than 60 beats per minute. So the ventricles are going to pump blood out of them at a rate less than 60 times a minute. Okay, right. Now the first thing to say is that this can be a perfectly physiological thing. You often find that in elite athletes who do a lot of exercise. Now, during exercise, what happens is obviously the cardiac output has to be very, very high. So often in people who are very fit, the heart undergoes a physiological hypertrophy. It becomes more powerful, it becomes thicker, the walls become thicker, and this means the ability of the heart to actually pump blood around the body becomes greater. So when these elite athletes are at rest, their heart, its stroke volume, the amount of blood that it will actually eject out every heartbeat is going to be higher than it would in an average person, and that means that the number of times their heart needs to beat in order to maintain a healthy cardiac output is going to be less. So because they have these remodeled hearts that are brilliantly remodeled because of the amount of exercise they do, their heart rates don't need to be as high, so they can actually have sinus bradycardia where the sinoatrial node is firing action potentials at a rate lower than 60 beats per minute, and that's perfectly healthy. Okay, so in elite athletes, sinus bradycardia can occur perfectly physiologically. What we're going to talk about is when sinus bradycardia actually occurs pathologically. So what sort of things can cause sinus bradycardia to occur pathologically? Well, the number one thing that I'm going to mention firstly is drugs. Okay, so certain drugs have the ability to slow the rate at which the sinoatrial node will actually fire action potentials down, and the absolutely typical example of a class of drugs which can slow the sinoatrial node firing down are the beta blockers. So I'll start by discussing the beta blockers. So the beta blockers, it's a sort of colloquial name for drugs that block or antagonists, competitive antagonists for the beta adrenoreceptors, so majorly the beta 1 and beta 2 adrenoreceptors. So we have discussed that on the cardiac muscle cells you have the beta 1 adrenoreceptor. There is another type of adrenoreceptor known as the beta 2 adrenoreceptor, and these are the main two beta adrenoreceptors. There is a third type as well, but usually, well, the third one is quite rare, and the drugs which block that are usually separate from the normal beta blockers that we talk about. So when we talk about beta blockers, usually we mean drugs that will bind to beta 1 or beta 2 adrenoreceptors and which are competitive antagonists for these receptors. Now, remember from your pharmacology what competitive antagonist means. It means that it binds to the receptor, blocks the ligand for that receptor, the agonist for the receptor, from being able to bind there, but does not actually trigger the receptor to activate the intracellular signaling cascades. Okay, so an agonist binds to the receptor and stimulates the receptor to activate the intracellular signaling cascades. An competitive antagonist binds to the receptor, blocks the normal ligand from being able to bind there, but then does not activate the intracellular signaling cascades and just blocks the normal agonists from being able to activate the intracellular signaling cascades. Okay, so beta blockers come in two flavours. There are the non-selective beta blockers, which block both beta 1 and beta 2 receptors, so they are competitive antagonists for both of them, and the absolutely prototypical example of a non-selective beta blocker is propranolol. Okay, a very famous drug. Then there are the selective beta blockers, and these are generally selective for beta 1 receptors. So there is then the beta 1 selective beta blockers, and we're actually going to use these quite a bit for the treatment of arrhythmias, as we'll see later on, but they can also trigger sinus bradycardia. So beta 1 selective beta blockers are drugs such as atenolol and metoprolol. So of course there are absolutely loads of these. If you go onto Wikipedia and type in beta blockers, you will get up huge great lists of all the different beta blockers, and you can learn them all if you like, but here are the major examples that you should be aware of. The non-selective one is propranolol, and two major examples of beta 1 selective beta blockers are atenolol and metoprolol. Okay, so these drugs then, if you are taking these drugs, they will be binding to your beta 1 receptors on the surface of the heart, and they will be blocking them. They'll be acting as competitive antagonists, blocking noradrenaline from being able to stimulate them. Okay, so that means that the chronic sympathetic tone that you'll be getting to the heart, and do note that, you know, the sympathetic and parasympathetic nervous systems, they're never completely off. Okay, there's always a little bit of sympathetic tone to the heart. Okay, yes, it can go up hugely if you're extremely stressed or if you're doing exercise, but there's always going to be a bit of sympathetic tone, which means that the sympathetic nerves will always be releasing a little bit of noradrenaline onto the heart, and activating the beta 1 receptors on the surface of the heart. Now, if you are taking a beta blocker, that will reduce the sympathetic tone, because now the same amount of noradrenaline is being released onto the heart, but it's not going to have the same effect because loads of the receptors are actually blocked by the beta blocker. Okay, so the noradrenaline is going to struggle to have its normal effect. In particular, let's think about the sinoatrial node. The sinoatrial node is going to be receiving less stimulation by noradrenaline, and it's used to that stimulation by noradrenaline. The stimulation by noradrenaline at that chronic tonic level, it's called the sympathetic tone, is what keeps it firing at its normal rate. Now that that's dropped, it's going to now fire at a slower rate. So if you take beta blockers, they are going to reduce the sympathetic tone on the sinoatrial node, and that's going to lead to the sinoatrial node firing action potentials off at a lower rate than it would usually. Okay, there are other drugs as well which can lead to the sinoatrial node firing action potentials off at a lower rate than normally, but the beta blockers are the absolutely crucial ones for you to be aware of. Okay, right, so drugs can cause sinus bradycardia. Let's think about other things that can cause sinus bradycardia. So hypothyroidism is another thing which can cause sinus bradycardia. So hypothyroidism means that your levels of the thyroid hormones, triiodothyronine and thyroxine, T3 and T4, are going to be far too low. Okay, so T3 will be far too low and T4 will be far too low. Now remember, T4 is the prohormone that you have circulating in the bloodstream, but it's not actually active. It arrives at tissues and is then converted into T3. There is a bit of T3 in the blood, but the main form that it's transported around the blood in is T4, and then it's converted to the active form at the actual tissue. Okay, so if you have hypothyroidism, hypo means too little, so too little thyroid hormones here, this can actually lead to sinus bradycardia. Now, why is that? Well, the thyroid hormones, they are incredible hormones. They regulate the basal metabolic rate all over the body. They regulate how much energy the entire body is using. Okay, so if you have very low levels of T3 and T4, your entire body all over the place will be trying to conserve energy. It will be lowering its basal metabolic rate. And the response of the sinoatrial node cells to too low T3 and T4 is to lower the rate at which they are firing action potentials. Okay, so sinoatrial node cells, in response to hypothyroidism, will start firing action potentials at too low levels. In addition, hypothermia, too low body temperature. Again, in hypothermia you're going to want to conserve energy, and the sinoatrial node cell's response to it is to reduce the rate at which it's firing off action potentials. So hypothermia is another thing which can lead to sinus bradycardia. The final thing that I want to put on there, which I'll discuss in a moment, is what's known as sick sinus syndrome. Okay, and in sick sinus syndrome, what has happened, and we'll discuss this in more detail after we discuss sinus tachycardia, because as we'll see, sick sinus syndrome can actually cause intermittent sinus bradycardia and sinus tachycardia. In sick sinus syndrome, something very horrible has happened to the sinoatrial node cardiomyocytes. Most likely there has been a myocardial infarction that has involved part of the sinoatrial node. So cells in the sinoatrial node have died. You've got scar tissue now in the sinoatrial node. The sinoatrial node is not well, hence it's called sick sinus syndrome. Okay, but we'll talk about that one later on. Okay, so all of these things then can result in the sinoatrial node firing action potentials at too low rates, and therefore can result in sinus bradycardia. Now, one of the ways then that you can actually treat sinus bradycardia, and the first thing that I should actually say with regards to treatment, is you would only actually treat this if it was symptomatic. Okay? Firstly, obviously, if the person was on a drug that was causing sinus bradycardia, then you would most likely just try and remove the drug and replace it with something else. Okay? If you have someone who is hypothyroid or hypothermic, you would address that issue first. If you've got someone now with sick sinus syndrome, then that's something that you're not going to be able to address with a different intervention other than with treatment for sinus bradycardia. So sick sinus syndrome is only really the one where this treatment is even going to apply. The other thing to say is that you would only treat someone who is actually symptomatic. Okay, so if you've got someone who's come in to see you about some totally unrelated problem, and you do an ECG on them for some reason, and you find that they've got sinus bradycardia, okay, but they have no symptoms, then you would not treat them. You would only treat them if they were actually symptomatic. Okay, so you treat illness rather than biopathological abnormalities, and that's going to be true of a lot of these arrhythmias. Often the treatment is reserved for people who actually have got symptoms. So if you have someone who is fainting all the time and is feeling really lethargic all the time and dizzy, then you would treat them for sick sinus syndrome and sinus bradycardia if that was indeed what they had. As I say, if they've got sinus bradycardia because of the other reasons, then you'd address those other reasons rather than going to this treatment strategy that I'm about to outline, because in those cases it's some prior cause that is causing this problem with the sinoatrial node, whereas only in this one is it actually a problem with the sinoatrial node's health. Okay, right, so what is the treatment strategy then for sinus bradycardia in the case that it is actually a problem with the sinoatrial node that is originally causing it rather than some other problem that's causing a problem with the sinoatrial node? Well, what you can have is a pacemaker fitted. So if you've got sick sinus syndrome causing sinus bradycardia, then you can have the treatment of an implanted pacemaker. And let me just explain to you what an implanted pacemaker actually is and what it's going to do. Okay, so implanted pacemakers then, they're a little device that is designed to stimulate the heart in place of the sinoatrial node. It's designed to replace the sinoatrial node. The idea is it will do exactly what the sinoatrial node does. It will stimulate an electrical signal to propagate. Okay? Now, pacemakers, they come in two varieties. You can have single chamber pacemakers and double chamber pacemakers. We'll talk about double chamber pacemakers later. We're at the moment just going to need a single chamber pacemaker because the problem is very simple here. It's just a problem with the sinoatrial node. Okay, and a single chamber pacemaker, as the name says, is just going to be a pacemaker that's going to affect a single chamber. You're going to have a lead going to a single chamber. Okay, so let me explain where you're actually going to put this device. So it's implanted in, it's usually put underneath the skin, under the left clavicle. Okay, so if you feel your left clavicle, underneath there's a nice sort of little space that you could implant one of these little devices, and it will just be implanted under the skin. And then the idea is that you take the lead from the pacemaker that you've implanted in that subclavicular space there, and the lead then goes into the left subclavian vein, through into the left brachiocephalic vein, into the superior vena cava, and then into the right atrium. So let me just draw a little bit of the anatomy here. Okay, so let's say that we've got the right atrium here. That is, of course, where the sinoatrial node is. Okay, that's the thing that we're trying to replace with this pacemaker, this single-chamber pacemaker. One of the major tributaries into the right atrium, along with the inferior vena cava, is the superior vena cava here. And that's actually how we're going to get our stimulating lead, or stimulating electrode, from the pacemaker device into the right atrium. Okay, now the superior vena cava is made up of two large veins in turn, which are known as the brachiocephalic veins. Okay, so here's the left brachiocephalic vein, and here's the right brachiocephalic vein. So I'll just write the name of that down. So this is brachiocephalic. And of course the brachiocephalic veins are made up of two enormous veins themselves. The internal jugular vein coming down from the head, so here is the left internal jugular vein, and here is the right internal jugular vein, and then also the subclavian vein, so it's like this. So here is the left subclavian vein, and here is the right subclavian vein. So I'll just write these names down. So we had internal jugular veins, and then we had subclavian veins, so internal jugular and subclavian. So those are all the names of these great veins. And of course our pacemaker is going to usually be on the left side in the subclavicular space, so maybe it's somewhere here. And what we're going to do is, when we implant it, we're going to have a lead going into the subclavian vein, like so. It'll then go into the left subclavian vein in particular, then into the left brachiocephalic vein, following down the superior vena cava, and then it will implant into the right atrial wall here. So this is the lead from our pacemaker. And it's only going to go into a single chamber, hence it's called a single chamber pacemaker. Right, and the basic principle now is really simple. This is going to activate the right atrial cardiomyocytes at the same sort of rhythm as the sinoatrial node would. Okay, it's going to replace the sinoatrial node, so it's going to send electrical activity down to the right atrium every 0.8 seconds. That will spread to the cardiomyocytes, and it will trigger the normal electrical signal to propagate through the heart, just as the sinoatrial node would. So there's the principle of a single chamber pacemaker and how we're going to use it to replace the sinoatrial node. So if there really is a problem with the sinoatrial node that can't be fixed by fixing something else, as is the case for all of these ones, so if you've got sick sinus syndrome, you can treat it by putting effectively an artificial sinoatrial node in, known as an artificial pacemaker here. Okay, so that's sinus bradycardia then. Now let's talk about the opposite problem, sinus tachycardia. So now what we're going to have is a heart rate of over 100 beats per minute. Remember, that was the definition of a tachycardia. Okay, so again what I want to start off with is talking about the different things that can cause sinus tachycardia, and then we'll talk about the treatment in the case where it actually is a problem with the sinoatrial node, rather than some problem that has, something before that going wrong that's then influencing an otherwise healthy sinoatrial node. Okay, so what are the causes of sinus tachycardia then? Well, firstly, I'll put on the exact opposite problem that we had here. Hypothyroidism could cause sinus bradycardia. If you've got the exact opposite problem, then it can lead to sinus tachycardia. So if you've got hyperthyroidism rather than hypothyroidism, hyper obviously means too much, so you've now got too much thyroid hormones. This also has another name. You can also call it thyrotoxicosis. Okay, in this case, of course, T3 and T4 levels are going to be far too high. Okay, and the major cause of hyperthyroidism is Graves' disease, where you have an autoimmune response which produces antibodies to the thyroid stimulating hormone on the tissue of the thyroid gland, and this then activates those thyroid gland cells to produce T3 and T4 at far too high levels. Okay, so Graves' disease is the major cause of hyperthyroidism, which I'll just add on there. Okay, so if you've got far too high T3 and T4 levels, then that's going to lead to basal metabolic rates all over the body going up. So the body will start increasing its basal metabolic rate all over the place. And the sinoatrial node cardiomyocyte's response to this is, okay, we can expend a huge amount of energy, let's just fire action potentials at a massive rate. Okay, so that can then result in sinus tachycardia. Another thing to be aware of is that if you've got something that leads to overstimulation of the beta-1 adrenoreceptors on the sinoatrial node cells, that can lead to sinus tachycardia as well. Now, what could lead to overstimulation of the beta-1 receptors on the sinoatrial node cells? Well, of course, drugs could, but there is another cause. If you had far too high circulating adrenaline levels, and this is important to be aware of. So I've told you about how there are these sympathetic nerves that will release noradrenaline onto the heart. However, there's another way to stimulate the beta-1 adrenoreceptors on cardiomyocytes, and that's with circulating adrenaline from the adrenal glands. Now, there is a condition where you can get a tumour inside the adrenal glands involving the cells that actually produce adrenaline, and this tumour will then lead to far too high adrenaline levels in the blood, and that adrenaline will then be stimulating the heart, particularly the sinoatrial node here, and causing far too high levels of action potential generation. Okay, so this tumour then is called a Pheochromocytoma, and I want to make sure I get this spelt right. Pheochromocytoma. Okay, so let me just draw a little picture of the adrenal glands. So of course you have two adrenal glands. They're also called the suprarenal glands. They sit atop the kidneys, and they have this sort of shape like so. And the adrenal gland can be split into two major portions, the adrenal cortex and the adrenal medulla. So the adrenal cortex is of course the portion around the outside, and the adrenal medulla, just a Latin word meaning the middle, is the portion in the centre, and it's the adrenal medulla that is of interest to us. The adrenal cortex produces all of the corticosteroids, so aldosterone, cortisol, other sex hormones, etc. The medulla is the portion that produces adrenaline. Okay, so it contains special cells that can produce adrenaline and will secrete it into the bloodstream. Okay, and these special cells which produce adrenaline are known as adrenal chromatin cells. Okay, and it's these cells, these adrenal chromatin cells, that you can get a tumour of in a pheochromocytoma, and when you get a tumour of adrenal chromatin cells, that's going to lead to adrenaline complete overproduction. Okay, so if you've got a pheochromocytoma, then you've got a tumour of these adrenal chromatin cells in one of your adrenal glands. Adrenaline levels in the blood, or epinephrine levels, those are the American and English names for it, so adrenaline or epinephrine. The adrenaline or epinephrine levels in the blood are going to go up, and this is adrenaline, just like noradrenaline. It's an almost identical structure to noradrenaline. It's got a methyl group stuck off the nitrogen atom, which noradrenaline doesn't have. So it's got one methyl group. That's all that adrenaline differs by. Okay, so very similar structure to noradrenaline. It can also bind to the beta-1 adrenoreceptors on the surface of the sinoatrial node cell cardiomyocytes, and that will trigger far too high heart rates. Okay, so a pheochromocytoma is another option here. Okay, other causes of sinus tachycardia. Also, let me talk about the fact that fever causes sinus tachycardia. So if you're very unwell, you've maybe got some sort of infection, then you'll get a fever, and fever leads to the heart rate going up via activation of the sinoatrial node, it leads to a sinus tachycardia. Now, the reason that fever leads to sinus tachycardia is debated. There are lots of different explanations that are all competing for being the reason for this. Okay, the major reason that I think most people believe is the reason that fever causes sinus tachycardia is that when you are unwell, you usually have inflammation at some area. So if you've got an infection, usually you've got inflammation somewhere at that site of infection. When you've got inflammation, the blood vessels at that site of infection are going to become much more permeable, so that fluid from the bloodstream can go into the area, and of course all the fluid in the bloodstream contains the proteins for attacking infectious agents. Okay, so often at a site of infection you're going to get this inflammatory exudate, as it's called. So blood volume is going to go down. Now when blood volume goes down, of course that's going to cause blood pressure to go down. And blood pressure is extremely safely guarded. Okay, there are mechanisms to bring blood pressure back up if blood pressure goes down. Okay, so it's a reflex then that when blood pressure goes down, you then get heart rate going up. So the general theory that people give for why when you've got a fever you get a high heart rate is that the fever, the inflammation causes blood pressure to go down, and then you get what's called the reflex tachycardia. Okay, so when people refer to reflex tachycardia, it means the sinoatrial node firing action potentials at a higher rate, causing a tachycardia to bring blood pressure back up, because of course if cardiac output goes up, that will raise arterial blood pressure. Okay, right, so fever, it's good to be aware that if someone's very unwell with an infection, they're going to have a very high heart rate. Okay, and it's driven through the sinoatrial node, so that can also cause sinus tachycardia. And the final thing to add on to this list, of course, is sick sinus syndrome again. So an actual problem with the sinoatrial node. Okay, sick sinus syndrome. Okay, right, so all of those things can cause sinus tachycardia. Let's now actually talk about sick sinus syndrome in a little bit more detail, because we've seen it now in the case of sinus bradycardia and sinus tachycardia, and then we'll talk about what the treatment options for sinus tachycardia actually are. Okay, right, so sick sinus syndrome. Sick sinus syndrome, as I've previously said, it's usually due to myocardial infarction that has affected an area of the heart involving the sinoatrial node. So the sinoatrial node has been damaged by a myocardial infarction is usually the reason for it. And what might have happened then is lots of the cells of the sinoatrial node might have died, scarring process might have occurred, so you've got lots of fibrotic tissue amongst the sinoatrial node cardiomyocytes, which wasn't there previously, which is going to disturb their connections between each other. So the sinoatrial node has been damaged, basically, and in sick sinus syndrome, this sick, unwell sinoatrial node can then go between causing sinus bradycardia and sinus tachycardia. So you get intermittent sinus bradycardia and intermittent sinus tachycardia. So sometimes this sick sinoatrial node might be firing action potentials at far too high rate, causing sinus tachycardia, and at other times it might be firing action potentials at far too low rate. It becomes very temperamental, basically. Okay, so it can cause both sinus bradycardia and sinus tachycardia. And as I've previously said, the treatment for sick sinus syndrome is generally to have a permanent pacemaker implanted. Of course, if it's causing symptoms. If it's not causing symptoms, then you don't need to worry about it. Okay, right. What other treatments are there then for sinus tachycardia? Well, of course, the other treatment that could be used for sinus tachycardia is beta blockers. Of course, if you've got some problem along the lines of hyperthyroidism, then again, you'd want to actually address that issue. Okay, fever, you wouldn't want to give beta blockers unless it really was causing a problem at the sinus tachycardia, because of course the sinus tachycardia is here to keep blood pressure high. It's part of the natural response to having an infection, so you wouldn't really want to disturb that. In a pheochromocytoma, beta blockers could be used to prevent this high level of adrenaline actually having an effect on the heart rate and therefore preventing sinus tachycardia. So beta blockers, we've been through their mechanism, of course. They will block the beta-1 adrenaline receptors and prevent the adrenaline or noradrenaline from stimulating the beta-1 adrenaline receptors on the sinoatrial node cardiomyocytes, and hence stop the sinoatrial node cells from firing action potentials at as high a rate. So that will reduce the rate at which sinoatrial node cells will fire action potentials. Okay, so beta blockers are a potential treatment, and of course we've already mentioned that for certain forms of sinus tachycardia, such as sick sinus syndrome, you would want to consider a single chamber artificial pacemaker to take over for the sick sinoatrial node. Okay, right, so that now is the completed discussion of arrhythmias that result because of a problem with the sinoatrial node. We'll have a break here, and in the next video what we'll go on to is discussing arrhythmias that arise because of problems in the atria. So we'll discuss atrial ectopic beats, we'll then go on to atrial flutter, and then atrial fibrillation.